Greetings. Welcome to the webinar. We've got a great discussion today with a couple of wonderful thought leaders. Fran Soistman, who is the Executive Healthcare Advisor for Healthcare Management and Transformation Advisory Services. And previously, Fran was with CVS Aetna. And in that role, he was the president of government services and worked on many different government programs, which he'll be sharing information with us about today. Also joining Fran, we have Dr. Paul Grundy, a dear friend of mine and longtime colleague. Paul is the Chief Transformation Officer at Innovaccer and is fondly known as the godfather of the PCMH movement. Nice to have you both.
Thank you, Adrian.
It's a pleasure to be with you, and it's a pleasure to be back with you, Fran and Adrian, on what's going to be, I think, a fascinating discussion about the social determinants of health.
Couldn't agree more.
Definitely. So let's get started. Before we get started, I want to just kind of lay a foundation and make sure our attendees understand the concepts that we'll be talking about today. First, health equity. We're hearing a lot about disparities of healthcare with the current pandemic, and health equity is a very important concept. I know Fran feels very strongly about this, and we'll be talking about it later. Equity, when we talk about equity, it's the absence of avoidable or unfair differences among groups of people. And those groups can be defined socially or demographically, geographically. You know, you can stratify them in different ways. When we talk about health equity, we're really asking, do people have a fair opportunity to attain their full health potential? And that opportunity is not biased, and they are not disadvantaged from achieving this potential. You might have heard the saying, your zip code is your destiny, which means that your access to a service like healthcare or access to quality healthcare isn't linked to where you live. And it is linked. So where your zip code is, that really could drive your destiny in healthcare. Paul, do you have any thoughts on this?
Absolutely. So what we see in equity is really how you can begin to support a population to get the care that they need. A really interesting case where we had one of our clients, and we began looking at the data, and we began to note that we were seeing an influx of folks with type 2 diabetes with hospitalization for hypoglycemic events. And when we looked at the data, what we saw was that these events were all occurring in the last 3 or 4 days of the pay period, right? So, you know, the lack of equity there was really about access to food. I mean, they were choosing between rent and food. And so their ability to have equity and not being hospitalized was really compromised.
Yes. Yeah, and you know what we've seen with the pandemic, it's really been exacerbated because if you're not starting from an equal footing, then if you don't have an equity in the prevention services, then your ability to recover from the virus or gain access to care for the virus is different. And we're seeing that in certain neighborhoods where socioeconomic factors are lower in our poor rural areas and our poor urban areas, that equity is really playing out in the amount of virus spread that we've seen. So
and death, and ultimately deaths. So yeah. I was going to say, I think the zip code, to take it even a step further, not only does it impact health, it impacts longevity. and the pandemic is, illustrious of that, on an accelerant basis. If you didn't have a pandemic, it still would define longevity more than your genetic code because of other environmental factors, access to clean air, water, food, healthy food alternatives. The list is vast. But the pandemic really brings this into focus, which is why those of us in the industry have been working on this for a number of years, but now it's now front and center for the American public, and which is great. I mean, that is a silver lining in what has been a horrific period for all of us to navigate, the COVID-19 pandemic.
So, the Tulsa, Oklahoma has sort of been front and center in the news with the recent events. And, in one of my visits there, I was told that in 4 or 5 of the zip codes, their life expectancy was anywhere from 10 to 13 years lower than in 7 others, right? And their infant mortality was really at third world rates. That was also true when I visited Jacksonville, Florida. Obviously, that's not equity, right? And when you see what's happening now on the demonstrations and the television and issues of do lives matter, are there lives that aren't treated equitably? Are there lives that don't matter, that aren't cared for in the same way as that wonderful slide you showed of folks able to watch the ball game versus being treated equally?
Yes. Very important points, and how these play out in social disparities, and just looking at the example here with how treating a diabetic is so impacted by their social situation, and it affects the outcomes thereof. So those are great points. So we've heard so much about the pie graph of the 20 to 80%. And, the question that we're always faced with is, how do we impact this other 80%, this outer circle, the community circle? Paul, any thoughts on that?
Yeah, so a great example that actually seems to work is Governor Douglas some years ago, working with employers and working with the state, created something called the Blueprint for Health in Vermont. And we've seen this in other parts of the world as well, where they took 2 cents out of every sick care dollar and they created the role of a community coordinator. And that community coordinator was responsible for bringing together all the not-for-profits, for organizing a plan around each patient in that community, 11 communities in Vermont. And I went up there and I spent some time in St. Johnsbury, Vermont. And I was sitting in the meeting once a month where they had the 37 not-for-profit agencies, the police department, the health department, everybody there. And a young Anglican priest says, never again will we allow one of our citizens to suffer an amputation because we don't have a plan for the patient. That plan was much broader than here's the drugs you take. That plan included Goodwill Industries that they didn't have a code. It included the nutritionist in the grocery store who explained how you need to eat. It included home services, housing services, et cetera. So, and if you look at places where you really have impact on total health of care, you begin to look at issues like housing first and other social issues, which are amazingly important. I don't know of a primary care physician in the world that thinks he's really going to have an impact on his patient if his patient is going to leave his office and go live under a bridge, right? I mean, that's just a...
Well, and Fran, I know you've done a lot of work in this area from the payer perspective. What are your thoughts?
Well, the payers, I think, have stepped it up over the last couple of years, primarily in the managed Medicaid segment and Medicare Advantage books of business in particular. It's a huge lift. It's complex. I mean, Paul touched on one of the biggest challenges among the Medicaid population, in particular, like the LTSS, which is a chronically ill population, is housing and finding the people. And so these are not softball kinds of problems. These are complex problems, and they're generational oftentimes. That doesn't mean they can't be solved. They can be solved, but it's going to take, tremendous efforts. It's going to take innovation. It's going to take a public-private partnership approach. I mean, the CDC's done a lot of work on this area. They've done studies with their HI5 initiative where they lay out community-wide initiatives, and I think healthcare is local, and I think the health plans that really understand and treat it local as opposed to national, so it's not a one size fits all. They need to understand the communities they serve, and those communities, they're not defined by county lines, right? I mean, that's just a map. They really have to get feet on the ground and understand the populations they serve, and understand their needs, and make sure that their initiatives are in alignment with those needs. So I think the level of sophistication is clearly advancing. It has to, and I also think that given the national conversation that's occurring on racism in America and discrimination, I really believe that over the next couple of years, you're going to see the bar raised in terms of what CMS expects from health plans in Medicare Advantage, and states expect from plans participating in managed Medicaid in terms of demonstrating results with respect to social determinants of health.
And Adrian, this not only impacts those folks who live in those zip codes with lower life expectancy, but it impacts all of us. I mean, my mom died in a nursing home of COVID-19 in March. She was cared for by service workers who probably at most made minimum wage, who probably had huge issues around preventing COVID, who, by the way, had to work. And 7 other people died with her, in 1 week, right? But in addition to that, it's the cost of healthcare. I mean, when you admit people into a hospital for hypoglycemia because they don't have food, it costs every one of us a huge amount of money. It increases our rates of insurance. It increases the cost of the hospital that get passed on. So it's a social issue that impacts society in general, not just those who are dying 10 years early.
Great point, Paul. Great point. And just to kind of further take this, now that we are in this new normal of a pandemic and delivering care in the pandemic, our risk profiles have changed, and folks who didn't used to be at risk. So, let's look at not necessarily the vulnerable, but folks who just are in a denser living area who, to your point, have to take those jobs that are necessary. Their risk profiles have changed. Fran, do you think the payers are acknowledging this and kind of changing the way they look at risk?
Well, I think among the commercial population, Adrian, the composition of the risk to self-insured business has changed tremendously over the last 10 years since the Affordable Care Act came into to law. So I think it really presents kind of a unique challenge for not just the payers, but employers, because employers are really taking more of the risk with the self-funded. They're taking all of the risk, actually. And, it's going to be very interesting to see, are they prepared to pivot and make the additional investments and transition from that claims mentality. And some of the more progressive ones have embraced value-based care, but make that pivot to understanding that they're going to need to make investments in the communities where their employees live, because it makes a difference in addressing these very, very issues. So that remains to be seen. As far as the payers and the risk, I think that there is growing recognition. I mean, COVID is still a very dynamic phenomena right now. I mean, it's, it seems like we're learning something new about, this particular virus every day. And the plans, the health plans are learning along the way as well. So I think it's going to be, kind of an evolving process. The one thing that hasn't really been identified that I am concerned about as well is the emotional part, the behavioral health part. We've had people, changing their work environment and are now largely working from home, some with their families, some by themselves. So you've got social isolation on one hand, and you have the whole family dynamic changing. Some of that's been very positive, and some of it has been very stressful. It's been hard on children who were accustomed to having play dates, and being able to spend time with their neighborhood friends. That's been shut down, and that's taking its toll. So I think that there are consequences yet to play out over the coming months, depending on how this second wave, how quickly we can get this under control. So I'm very concerned about that element as well.
Good point. So let's take poll one with our audience and see where their thoughts are on this. I'm curious to see if you in your organizations are addressing these social determinants that really have become so important in understanding our patients and their risk. If you'll take the poll and let us know, are you looking at social determinants and managing those through manual coordination, or perhaps you're using some technologies to help manage the social determinant related risk? Perhaps you haven't really started working on this yet, but do want to start soon. Or perhaps you don't really have it in your roadmap and you're not looking at social determinants. So let's take a moment and let participants take the poll. Paul, sorry to hear. I remember when you told me about your mother, and that was quite a story. And the nursing homes are getting so heavily hit. I just wonder, if there's any relief out there for the folks who are on the front lines at the nursing homes.
It's exactly right. And I guess, my mother was in stage 7 of Alzheimer's and really declining pretty rapidly. But, two of the nursing staff and some of the support staff also died of COVID. And, they were in their 30s and 40s, and all of them were immigrants from West Africa in the part of Houston my mother lived in. Which was really sad,
Yeah. So what does the results on the poll look like? Let's see. Okay, so we do have almost half of the respondents are managing through manual coordination. Well, that's good to hear. We've got quite a few looking, using technology to help manage, a third of the folks, and then 22% who are not managing yet, but looking to start quickly, and no one is not doing it or doesn't intend to. So that is good news for understanding our patients.
Yeah, that's great.
Yeah, so Fran, you're happy to see that.
Oh yeah, absolutely.
Awesome.
It's a journey, and so I think I just encourage everyone to stay with it. There's going to be points where you'll get frustrated, and because results don't always materialize immediately, and we kind of have that need to see things quickly, but we can make a difference if we work together. And I do think we need to coordinate more with local, state, and county, city governments. That too can also make a big difference on how we attack some of these challenges.
Yeah, it looks like folks have definitely leaned in on this, and we've had some great zip code level analysis done by the CDC, and hopefully people are mining into that research to understand the risk, and this goes beyond the pandemic for sure. Social vulnerability is an idea, like you say, that folks have been looking at for years and years. As we,
I
yeah,
would
go
like
ahead.
to stress that when you're dealing with an infectious disease pandemic, you're dealing with the weakest link, um, being the potential super spreader, right? I mean, it impacts us all.
Yes. And so when we talk about how do we attack this problem, a problem that is, a very heavy lift, to Fran's point. Um, and there's all kinds of tools out there and programs. I'm curious if either of you, would like to speak about any programs that you've been involved with or you think are very successful. Paul?
Sure. So, I mean, I think of this simply as three legs of the stool that have to be that have to align, right? So there's the cultural shift and the training that has to happen for the workforce and society to understand that we're no longer going to deliver an episode of care. We're going to manage a population proactively, and we're going to manage it from the community level with the support you need. The second, and I think this is really key, is there's only one way to herd a cat, and that's to move the food. I mean, if you continue to put all the food out in the fee-for-service world, you're going to get too many services. One example of that is Maryland, where where they've actually defined how much a hospital can make, and a bottom in a bed, a head in a bed is no longer necessarily a profit center for them. So it's in their interest to reach out to the community and keep those type 2 diabetics from showing up, because that's a cost to them and not a profit to them. In that shift towards value, in the shift towards accountable care, increasingly it's in the interest of both the patient and the hospital and the physician to keep them out of the hospital and rather than in the hospital, which really has a positive impact all the way around. And I think the third element for this, and we're making some progress on that, is the technology that allows us to actually see the data around what we need to plan for every person in our community, right? To understand, as that 32-year-old nun said in St. Johnsbury, never again will we not have a plan for our citizens that allows that amputation to occur. That example in Vermont, we saw a 60% reduction in the complication of diabetes because there was a comprehensive plan beyond clinical care.
Yes, great point. And, a couple of the states that have done so well during the pandemic, Vermont and Rhode Island, were notably the early adopters of very vigorous population health management and at the primary care level through the patient-centered medical home model. So I think that they can serve as shining examples to other states of how to really wrap your hands around this. You talked about training, and I know, Fran, I've studied your background, and I know that you are very passionate about mentorship and have done a lot of work with the African American employee communities. I'm curious if you have any thoughts on how we can really bring our payment and our care delivery stakeholders up to speed on this new way of caring.
Well, thank you for acknowledging that. There is work already underway. I mean, it's happening in many parts of the country. It's not broad scale enough, but it's growing. I think value-based arrangements will be an accelerant for this. The fee-for-service model, kind of perpetuates an inefficient healthcare system. And the faster we can move away from that model, I think the better we're going to get to putting more and more focus on the outcomes, and the outcomes bring into light all of these things we've been talking about for the last 25 minutes, the disparities, the inequities, the problems that can be solved, but it starts with sort of the data, and we don't have to reinvent solutions everywhere. We can take things that have worked in other markets, other parts of the country. They may just as well work somewhere else, solving a very similar challenge. There may be needs to tweak it here and there, because of differences in the demographics, but nevertheless, there just needs to be a lot more coordination, collaboration among communities, providers, payers, government. I mean, think about the amount of money at both the federal, state, local level that's spent on many of these social issues, and it doesn't feel like we've moved the needle. But if we, if we can bring in the health component and now have something to really measure it by, because that was the problem. I think we never had anything to really measure it by that was sustainable. I think we could get better outcomes, because so much of this is social, and it's how do you solve it and how do you make the problem go away once and for all. But we're talking generational challenges here, right? I mean, education, literacy. These are very, very complex challenges, but our nation has stepped up and solved great challenges in the past, and we can step up and solve these as well.
Yes, and we've also seen the incredibly rapid adoption of telemedicine and other virtual care technologies. So I think healthcare has actually proven to itself that we don't have to move slowly, which has been, an eye opener for many of us. Paul,
that's a great example. If I could just make a comment and turn it over to Paul. Sure. One thing that we learned through this pandemic very early on is that we learned it through sending children home from school, college students. Not everyone had Wi-Fi capability. You can give them laptops, but not everyone had Wi-Fi. And you need the Wi-Fi to make telehealth work. So it's creating, that's a disparity, right? The technology inadequacies is a disparity that has to be solved in order to put this new technology to work, because it's there. It's no reason, and it's not going to work differently in a different zip code as long as you enable it with the same support. So, Paul, I'm sorry.
No, that's okay. It's that little kid looking at the wall instead of the game, right? It's exactly from that first slide. Yeah, I mean, at the University of Utah, where I've been on the faculty for a number of years, we began by looking at our community and the resources in our community in terms of training. We reached out to the local high schools and we identified kids that wanted a career in healthcare, and their last 6 months of high school, they spent in a program training to be a medical assistant. We put our medical students in that same program, right? They were also being trained in their first triage, how to be MAs. And, we now have 15 primary care doctors that started that way. They come right out of the community, understand the community. The last one I met was a Somali immigrant. But beyond that, the next step in medicine is the chief complaint. What's wrong with you? That I remember taking very, very early in Introduction to Clinical Medicine. And at University of Utah and other places now, it's no longer four medical students banging up against a patient asking that question. It's a nursing student, it's a pharmacy student, it's a medical student, it's a behavioralist asking that question. Really, really beginning to understand from day one that this is going to be a team sport, that, we're going to actually be in this together. But that cultural shift and understanding of you really need to engage the community. one really interesting system that I talked to reprogrammed their cleaning staff, you know, who were the lowest paid in the community, but had the closest access to the community to be the community workers, you know, to really be the translators between the sick care system, you know, and the community. Yeah, I could go on, but that's the
Yeah,
idea.
no, that's a great example. Just reimagining everyone's role, I think is so important right now. And, you know, this was a popular slide making the rounds, and one that I really like because it really shows how, you know, we used to think moving upstream was patient-centered medical home, you know, creating that medical community around the patient. Now we're realizing that has to expand into the medical neighborhood, which of course was something that our PCMH founders knew was going to happen, but we had to start with the baby steps. But now we're really at that point where we have to move into the community. And, you know, to the points that you both have been making, hopefully our healthcare colleagues at Google and Apple will understand that none of this will move forward until we have national broadband and these public-private investments that you were speaking of, Fran, will be looking at some of these root conditions. Any thoughts on moving further upstream that we haven't spoken to yet?
So I was asked by Jeremy Hunt, Secretary of State of Health, to come over and work with them on the medical home concept in England. And what was a real revelation to me was that their thought process of what that was going to be was so different than what we started with, Adrian. When I sat down in the first pilot in the first location, which was in Plymouth, it was at the community hall. And in that meeting was the person responsible for making sure that everybody had fuel. was the person responsible for the farmers market, was the housing authority, was all the mental health authorities. So their concept of a medical home was really much further downstream, you know, making sure that there was adequate education, et cetera. And when you look at the combination of spending in the United States versus England, we say we spend twice as much money with terrible results. But if you add the cost of what they spend in social services with what we spend only in healthcare, it's about the same amount of money. We just spend it wrong.
Gotcha. Well, and of course, which makes me think about Medicare Advantage and the great success that that partnership kind of program has had. Any thoughts on where MA might be heading, Fran?
You're right. MA has had great success, and it's gaining even more popularity. It's growing, you know, at double-digit rates, and I think it's I'll give credit to CMS for providing the plans with greater flexibility to work with members, beneficiaries, both holistically on an individual basis, where in the past, you know, you had to give everyone the same thing, whether they needed it or not, which was cost prohibitive and wasteful. So they provided the plans with greater flexibility, but just them embracing social determinants of health over the last 2 years through supplemental benefits is a huge step forward for the program, and certainly something that, you know, further widens the gap between original Medicare and Medicare Advantage. So the value proposition continues to increase in terms of how beneficiaries can really, I think, benefit, pardon the use of the word twice, by a private plan versus the original Medicare. But they also know that it's a political animal in some respects, and things can change depending on the ideology of who's leading and budgets. So I hope that we don't let politics get in the way of what is a great program that's got measurable results, demonstrating, you know, a continuous improvement through the STARS measures, it'd be a terrible disservice to particularly accelerated aging population.
Yeah, and Fran, I've heard you talk about managed Medicaid and what they are doing and what they might be focused on with the health disparities. Can you talk a bit about that?
Well, this is speculation on my part, or a hypothesis, call it what you like. I just believe that it's inevitable. Some states will move faster than others. Probably states where there has been perhaps greater unrest about racism in their state, discrimination, and the need to address these disparities. Perhaps those states that have been harder hit by COVID among a Black and Brown community. And that's the right place to start. I mean, we got to go beyond acknowledging the disparities. We've got to start solving the disparities. And the plans can't do this by themselves. So let me make that statement right up front. The plans are part of the equation to solving it, but they just don't have the ability to solve housing issues or clean up the air pollution or water, water contamination or whatever. But they can affect so many other areas, either by themselves or working in concert with the community and with the state. And that's really where I think there's going to be greater emphasis, and I think they're going to be measured at some point. They'll be measured much like HEDIS is measured. How quickly they get there, I can't predict, but at the end of you can't manage it if you can't measure it, right? So at the end of the day, you're going to see measurement, and that's how plans will be scored.
Good points. Yeah, so as Paul always says, if you really want to see change, if you want to herd cats, you have to move the payment, you have to move the food. And so we do, those of us that have been involved in healthcare transformation, we've looked to the payers to help drive the change because they have, they have the payment and they can really drive behavior change, but they can't do it all alone. On poll 2, let's talk about the extent of awareness that you have of your patient's risk. So we know that you're managing the risk. Do you have any access to information about your social determinants? Are you collecting it manually so that you do have some insights? Are you assessing this risk, or are you using it to stratify? So if you're collecting the information, conceivably you would be using it to stratify your patient population. But if you're not assessing it, you're not stratifying. And then the last choice would be, are you incorporating these insights into your population health management workflow? So choose one of those for us. And Paul, any comments on having insights into the social factors of your patient panels?
So I was thinking of an episode that I had recently. I was just before we couldn't travel anymore. I was on the other side of the Rockies in a small town over there, and I was meeting with the employers. There were 3 school boards that were in that meeting that night, and they were telling me about 7 of their employees that ended up with end-stage renal disease. And when you look at that, what was happening, these were $11 an hour cafeteria workers, et cetera. They had high deductible healthcare plans, and they never had $125 to go see a primary care doc. So, for lack of their hypertension being treated, they're in costing the society a huge amount of money. So one basic element when I think about this that has to happen is we have to do benefit redesign. We should have first dollar primary care. It is an investment to make sure that your that your hypertension is treated, et cetera. And we know that these things that aren't cared for because, we really, even if you're insured, you have actually lack of access to that level of care, is exactly what hammers people into being on a respirator in an intensive care unit when they're hit with a virus like COVID-19.
Good point. Okay, do we have results back for the poll? Okay, so it looks like 36% of folks are collecting that data manually. We thank you for your service. I know that is a heavy lift, but you're making an impact. And 31% are actually incorporating these insights into their population health management workflows. That's really exciting. Any thoughts, Fran?
Well, it's impressive that they're able to capture it and to already reflect it into their work streams. That's great news, and I'm sure they're making some course corrections along the way too, because things don't always work and get the results you're looking for right away. But the fact that they're able to measure it and work into their workflows is great.
That is great. So one of the ways that we move forward in this conversation is to, as you could see from the poll, almost a third of the folks either weren't able to collect the data or weren't able to assess the insights. So we have to support our teams with better technology to do this, and we have to work it into that population health workflow. I have a guest with us today, Akanksha Sani, who is a product manager from Innovaccer, who focuses on building solutions to pull the management of social determinants of health into the care management workflow. Akanksha is going to talk to us about different kinds of technology solutions that might help in this. Akanksha?
Hi everyone. Happy to be here and talk about SDoH. The results are definitely interesting, and I hope our solution can help people, activate the SDoH data, as we call it. So our solution is built on these 4 pillars that activate the SDoH data at the point of care. We start with identifying the patients who have high social risk score and providing them with this data and automated workflows, providing every stakeholder in the care team with workflows that help them work on those patients who have social needs. While we have these workflows in place, it's very, very important that we cover the last mile and actually close the referral loops of the patients with the community resources. Now that we have our 3 pillars, which talk about the whole process of catering to the patients and the population's social needs, it's very important to, pause for a bit, take a step back and see whether there is any course correction that we need to do. And that's where measuring the outcomes with that dashboards becomes extremely important. So as we move to the next slide, I would talk about the workflow that we leverage to address SDoH on a granular level. As you can see that we stratify the overall population using our proprietary social vulnerability index algorithm. In addition to that, we also conduct assessments which help us pinpointedly identify risk factors of our patients. With these 2 pieces of information combined, we leverage our care management, provider engagement, and patient engagement applications to start addressing the social needs. Through the combination of the first 2 applications, care management and provider engagement, we refer patients to community resources and leverage patient engagement app and the community resource app to finally close the referral loop and ensure that there is no single patient who falls through the cracks. And lastly, we review the impact of our SDoH program, and if there are any areas that we need to improve upon, we review the progress through the dashboards. So let's zoom a little bit into how the proprietary SVI works on this slide. We have extracted almost 60 elements across different categories like socioeconomic determinants, housing composition, access to healthcare, minority, etc., for each and every zip code to calculate the social vulnerability index. To evaluate the accuracy of the SVI, we observed the data for the Nassau County in the New York State. As you can see here, we try to correlate the SVI with health outcomes to see whether our SVI is accurate or no. As you can see, the red regions on the left side in the slide, they denote high SVI. And when you map those regions to the right side of the slide, you see high ED and IP visits as well. So it validated our hypothesis and verified the accuracy level that there is a clear correlation between high SVI and the health outcomes that we see here. So let's move to the next slide and take a look at the first step of SDoH data activation in more detail, which is to identify the patients who are more predisposed to social determinants. As we saw from our poll results, that there are a lot of people organizations who are still collecting the SDoH data manually. What we do is that we combine the SVI data with patient-reported SDoH data to build a personalized machine learning algorithm that generates a patient-specific social risk score. We divide that risk score into high, medium, and low categories so the health systems can focus on the most vulnerable portion of the population without having to manually, collect the SDoH data of each and every patient. And I think that's where the power really lies. Using this personalized social risk score, we really help organizations refine their SDoH strategy.
Yeah, I think you're right, Akanksha, and I think that our poll actually supported that actually collecting the data is the hard part.
Absolutely, Adrian. Now that we have activated the SDoH, we have the activated SDoH data at our disposal, it's extremely important that we empower the care teams to take action on that data. We have the ability to conduct assessments and interventions at every step of the process using all kinds of devices that you might have. A lot of our community health workers and our social workers are always on the go around the field with the patient at their home. So it's very important that they have whatever device they have at their disposal, they're able to conduct those assessments and conduct those interventions while also having a personalized engagement with the patient. So be it a desktop or a tablet or even a tiny mobile phone, they should be able to cater to the patient's social needs. You can refer these patients to community resources. You can share tasks with the patient's care team. And while we're easing things for the social workers with these workflows, I think the real power lies in bidirectional communication between stakeholders and real-time broadcast event information across the board. A social worker's efficiency is a key lever in this process, and it's important that every workflow that we have is able to increase that multifold.
Great point.
In the next slide, let's take a look at the most important step in this process, which is closing the referral loops. And I think this is where a lot of social workers and community health workers, face issues. We have conducted interviews of many of the community health workers and try to figure out where are the patients falling through the cracks. It's important that the social workers have all the possible support at their disposal when they need to identify the right community resource and collaborate with it. We give them access to multiple community resource directories. I think one is just not enough, especially in the pandemic times, including And Bertha, which is one of the largest ones around, so they can find the most fitting community resource for the patient in the least amount of time. We also have automated workflows for referral loop closure. I'm actually going to demo that in a few minutes. And while all of these events are taking place, it's important to ensure that every stakeholder, including the patient, is notified of them in real time.
Yeah, and Akanksha and I actually did some product research in Chicago where they have such a strong community of social workers engaged. And to your point, one of the top problems was communication. So this communication between the social stakeholders is so important.
Absolutely. So yeah, let's see how our community resource application is solving a major problem that these resources face. It's important to understand that not all community resources are equally funded, or have the capacity to make additional investments in technology. A lot of their workforce is actually working on volunteer basis and is always on the go while catering to the social needs of their patients. They need something that is handy, that is easy to use, and that does not require a steep learning curve for their volunteers who change quite often. We don't really want them to have one additional step every time there is a new volunteer who wants to help out the community. We want everyone to be helped out as soon as possible, and we don't really want that there is a training going on and there are new laptops that need to be installed just to close the referral loops. This mobile application that resides with these community health workers builds a bridge between social workers and care managers and community health workers using bidirectional communication. This way, the referrals do not fall through the cracks. The referrals actually get closed, and we can finally sleep peacefully that the patient's social needs were catered to. So let's go ahead and go through an action. All right, let me share my screen. Okay, so as you can see here, I have the care management application open, and we are in the risk profile of our patient who is called Jordan Simmons. As you can see through the SVI, she has 81.0 SVI, which denotes that she is highly socially vulnerable. We have divided the SVI into 7 major factors to let you understand which are the levers that need to be catered. So for Jordan B. Simmons, I can see that she has high socioeconomic and high food insecurity issues. Now that I know that, as a care manager, I know that these are the factors that Jordan needs to be covered for. I can go inside the care management screen and look for community resources who can help Jordan out. Let me go ahead and refer Jordan to a community resource that can help with the food insecurity. We have the option of referring to Ann Bertha resources. We also have the option of referring to partner resources who have the mobile applications. Because Jordan B. Simmons was from the zip code 52240, we identified the most relevant and the most fitting resources that could help her. Let me go ahead and look at all the resources that we have at our disposal for her food social need. As I can see here, there are 4 to 5 resources that I've identified. There is a Whittier Assistance Program. I can see all the details about this program. Jordan is eligible for this program. They support an English and Spanish speaking people. It's free of cost. I can finally go ahead and refer this patient for her food needs. If there is any proposed appointment date or an engagement scheduled that Jordan is comfortable with, I want to let the community health worker know about it, because through our interviews, we've also identified that there is a high chance that the patient would fall through the crack because we did not have a conversation around what is the perfect time when the community resource and the patient can get in touch. So I send the referral from my care management application here. Once the referral is sent, the community health worker would get a notification about it on her phone. And this application is available on tablets and web as well. So if you're on your laptops, you can get the notification there. If you're on the go, you can get the notification on your phone. I can see that Molly sent me a referral request. I get inside the app, I see all the referrals that I have. I see that I have a few volunteers working for this resource who are already catering to 38, 22, 10 referrals. Let me see how can I help Jordan B. Simmons today. Jordan B. Simmons is expected to arrive on 18th of March. She requires support with her food issues. She's the health coach who introduced her, was Molly. I can accept this referral. I assign it to myself. Now, the good thing about this is, like I said, it's very important that the care team gets a notification in real time and understands what is happening here. So when I go back to my care management application, I would see that the referral has already been accepted. The same way, now, once we have talked to the patient, understood the requirements that the patient has, and want to finally close the case if the needs have been satisfied, we can click on close case and update the status accordingly. So the bidirectional communication and the real-time broadcast of the information amongst the stakeholders is actually closing the referral loop automatically and helping out the patient in their social needs that they have.
Very efficient is the word that comes to mind. Any comments from Paul or Fran?
Yes, so cool. I was sitting in a practice where this was actually being used, and I can tell you, I was concerned that the patients would be concerned about privacy issues and those sorts of things. The patients were so pleased that their provider, their practice, their trusted healer cared enough about them that they would ask them about these kinds of issues. They would engage them on these kinds of issues. And when you talk about, reducing hospitalization for ambulatory sensitive conditions, I mean, this is so key. So this is exciting.
Yeah, I'd echo that. I think that there's a trust between a patient doctor in that relationship, and there's going to be greater willingness to share than perhaps to a third party. There may be an embarrassment in some cases of sharing some information. So I think this tool is phenomenal.
Yeah, one thing we've heard from one organization that's using this tool is when you sit down to have these conversations with patients, you really want to focus on one issue. It's just too overwhelming otherwise. Folks that are vulnerable, they have many issues on their plate related to the social determinants, and you would never want to sit down and say, let's try to tackle these 3 issues. You really just want to focus on the one that's the most important to the patient at the time, and just worry about that at first. That was some advice from an ACO we work with in the Midwest. We have some great questions. Why don't I just see what our experts are thinking along these lines? So I like this one. There's area agencies on aging have been experts at bridging the needs of the aging population and populations with disabilities. And I'm curious if you're aware of anyone that is kind of working, any healthcare organizations or payers that are working with the agencies on aging, and instead of trying to reinvent the wheel here.
Yeah, I'll go ahead and start. I know Aetna, Aetna's Medicaid business has worked with the AAAs in virtually every one of the markets where they have a Medicaid presence, and those relationships are invaluable. I mean, to the person who asked the question, I mean, they obviously get it, so it's really important to tie in with them. The AAAs are really a connection point to the community, and you're missing an opportunity if you're not linked in with them.
So important. I mean, when you stop and think about the support you could actually wrap around your patient. I was in a small town in western Iowa, and the community resources for aging, the Meals on Wheels, the YMCA, and other social agencies. There are many people who would love to jump in and support their population more effectively, support their community more effectively, if they had the information, if they knew how to help and when to help. But it's going to make a huge difference if you have if you have the folks that deliver Meals on Wheels stopping and checking and making sure that other issues are supported. So yeah, agree.
Yes, that question actually addresses two of the questions in our list, and we've come to the end of the time here. Thank you so much to Paul and Fran. Any closing comments? Paul?
Stay healthy, you guys, and stay engaged in your community. You can make a difference.
Yeah, I would say, it's really important to get your employees to see some of these challenges up close and personal, and take it away from the theoretical and make it real for them. Let them actually experience it, and that will intensify the passion and that urgency to solve it. So if you're not taking it, if you're not doing that today, I would encourage you to do that. And pleasure to be here today, Paul. Great to work with you today.
Thanks, Adrian. Thanks, Fran.
Thanks to both of you. That was a call to action from our thought leaders. Everyone have a great day.
Bye-bye now.
Bye.